So I'll just get that going. Great. So thanks everyone for joining at We Are the Missing Middle program, and we will be talking today about family-centered care. And a very, very hot topic in family-centered care is confidentiality, especially with teenagers and young adults. We know that they're building more independence, but often still navigating that role of involving family for supporting them. So that's what we'll be diving into today. Feel free to move to the next slide, Steph. So before we begin, we do want to acknowledge that we're presenting today from the traditional, ancestral, and stolen or unceded territories of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations. As we talk about family-centered care today, we want to acknowledge the role that colonialism and ongoing systemic harms have had on the family system within Indigenous communities through such practices as the 60s scoop, residential skills, and even today, the overrepresentation of Indigenous youth in the foster system. We want to acknowledge that ongoing harms have served to impact families. And so in the work that we all do in trying to better support families and be there for them, we want to acknowledge that allyship and ongoing learning is a very important part of all of us supporting families. Next slide, please. So who are we? For those who haven't met us yet, my name's Sarah. I'm an occupational therapist, and Steph is here too. I don't know if you want to say hi, Steph. She's been having some computer troubles.
Hey everyone, my name is Steph. I'm a registered psychiatric nurse by background, and I'm the team lead and consultation nurse on the transition and linking to care team with Sarah.
And our third team member is Otto Lim. He's a social worker. He's on spring break with his kids this week, but many of you might know him from the mental health world as well. So we're a multidisciplinary team. We're a small but mighty team, and our goal is to be a consultation team to improve the service experience for 16 to 24-year-olds with moderate mental health and substance use concerns and their families. So what that means is not only are 16 to 24-year-olds straddling the child and youth and adult mental health systems, but having more moderate mental health where walking into the GP office or foundry might not be the right fit for them, but they might not also be needing a very intensive tertiary or acute stay. So thinking about a lot of these young people who might be showing up to the emergency department or having a hard time finding services that are meeting their needs. That's who we are aiming to support through this Missing Middle program. So our goal is to build healthcare provider capacity and understanding of this population through consultation and education. Our hope is that our education will ease the transition process for young people as they go through their developmental and mental health journey. And other parts of our program involve, we're building out virtual training programs for clinicians across BC and also looking to advocate for some system changes for some better services for this age group. Next slide. So for learning objectives today, we're going to review trauma-informed care principles and practice in relation to family-centered care. We're going to highlight the value of including family or chosen family in treatment, and then really diving into what most of you are here today for, some really tangible conversations around privacies, how to kind of look at clinical practice implications with working with families around confidentiality, and demonstrating some comprehension and application of these through some case studies. So Steph and I aren't easily distracted. So please, if anything comes up and you want to ask a question midway through, feel free to raise a hand or unmute. You can also throw things in the chat or participate at any time. We recognize there's a lot of knowledge in this group. And so some of these concepts might seem more like review, and some of these hopefully will help you have a fresh idea or a thought for some ways to approach family-centered care. But we really welcome discussion and sharing resources or things that have worked for you in your practice. So just to ground us, the definition of family. So we use the term all the time, but when we refer to family-centered care, we're really looking at family being included as a really valuable part of the care team. So really part of that interdisciplinary team. This might include things like involving them in assessment, education, decision-making, discharge and safety planning, and resource connection for their loved one. And it's really important to note that anyone that the patient or client has identified as part of their care team is referred to as family. We know that it's not always a very traditional nuclear family, and some folks may have more chosen families. So this could include people such as parents, guardians, so an MCFD social worker, a parent-appointed guardian, a temporary guardian, a friend, extended family members, dependents such as children, partner, siblings. And then we just have an asterisk that if friends or family under 19, they obviously can also be included in the patient's care, thinking about friends for a teenager, for example. But for the purposes of the Mental Health Act, when we think about things like next of kin or notification, people in the care team do need to be 19 plus. So that's why we made that distinction. So trauma-informed care, this whole presentation isn't trauma-informed care, but we did really briefly just want to touch on trauma-informed care in relation to family-centered care. So we know that the effects of trauma are often misunderstood, both by those who are directly experiencing them and the people in their lives. And this misunderstanding can lead to further harm, ineffective support, or negative labels. Many of us have probably heard terms or labels getting thrown around like, defiant, resistant, angry, challenging, bad. So it's important to acknowledge that even small, repetitive, stressful experiences or chronic stressors can have a cumulative effect, similar to that of a single major traumatic event. What matters most is not just the events themselves, but how each person uniquely processes and feels about those experiences. So we know that two people can experience the same thing, and one may experience PTSD symptoms and the other might not. So it's a very personal experience. And in relation to family-centered care, we just want to acknowledge that traumatic experiences, which when we're working with those with mental health and substance use, there can have been some very, very scary experiences leading up to admission or to connection with your team. It can deeply overwhelm patient and families in mental, emotional, and physical ways. So recognizing this can foster compassion and support. We also know that descendants of individuals who experience trauma may experience similar emotional and behavioral issues, even if they didn't directly experience the trauma themselves. As many of you or all of you are well aware, that term is intergenerational trauma, and that's used a lot, particularly in relation to Indigenous communities in Canada. So I'll have the next slide, Steph. So I won't go through this in depth, and we will be sending out all of these slides. We also will have a recording, and so you'll have access to both of those after. But in thinking about some values or principles of trauma-informed practice, safety, trustworthiness, choice is a huge one, collaboration, and empowerment. These are not only great for trauma-informed practice, but also great for family-centered practice. So I think they go really hand in hand. Next slide. So what do trauma-informed systems for families look like? We know that considering things like power and control are important. That emphasis of doing with and not doing to, really helping to explain the what, why, and the how to help them get on the same page, offering real choices, flexibility, understanding, and being able to identify things like fight, flight, freeze, or fawn responses, and how that might show up in family members or in our patients. And focusing on strengths, not deficits, and examining those power issues within our organizations. So the reason we're all here is talking about family-centered care. We all know it's important, but we also know there are a lot of barriers and challenges in giving good family-centered care. So we'd love to hear some barriers that you have encountered to providing family-centered care. So what I would invite everyone to do is doing what's called a chat blast. So just going into the chat and writing in an answer for yourself, but not hitting send just yet. And then in about 20 seconds, I'll get everybody to send it at the same time, so all the responses will come in. But what are some barriers you have encountered to providing family-centered care? I'll give about another 10 seconds to get your responses typed and ready. Okay, and feel free to hit send. Yeah, so just reading through some of these here, having knowledge of cultural norms, time with family. Sorry, that looks like two. Knowledge of cultural norms and then the time that you have with family, so limited time, I think, if I'm reading that right, Kelly. Clients not wanting any family involvement, that's definitely huge with this age group, and a lot of the case studies we go through later will talk through those challenges. Challenges with having enough time or policy and organizational support to engage families in a meaningful way. Time and lack of resources. Overbearing parents, conflicting goals or views on issues, culture clash, lack of resources or funding, definitely. A youth does not want suicidality to be shared with parents. Family members might have resistance to their own trauma. Geographical distance, these are great. So many of these are coming in. Resources, clients providing verbal consent, but changing their mind again and changing their mind again and again. And that's a really important point from Monica, is we know that consent is an ongoing conversation and people can change their mind over time. Sometimes they, over time, will decide that they're comfortable with sharing more, but a lot of the time it can be the opposite. And as a team, it can be really difficult to kind of keep up with that and make sure that we're being in line with consents that we currently have. And that timeline from a youth agreeing to family involvement to appointment date, definitely. So that was a really great list. We have just some other ones here that are complementing the ones that have been said. So just going to only read out the ones that are different. So we've talked a bit about interpersonal conflicts between family, or the perception that family dynamics are contributing to a client's mental health. So a common thing I see a lot with BC Children's, as an example, is there might be there might be two parents who are separated, and so they might have very different ideas of how they want their loved one experiencing mental health support, and what's happening in each home might look quite different. So that lack of consistency. Different goals, values, and beliefs within family regarding treatment. We have a lot of team members here from, we work quite closely with a lot of the teams in Richmond, and in Richmond, we know that there's a huge diversity of cultural backgrounds in Richmond, and some of those cultures, particularly from Chinese background or Indian background, for some of them, they describe that often mental health is not talked about as much in those cultures. And again, there's so much difference within cultures, but just as a general pattern that we hear from members of that community quite often is it can be really hard to talk about these things with their families. Patients who lack a strong support network or whose main support network is not local. Think about someone who's maybe at the airport or someone who's an international student. Language barriers, differences in biological age and functional age. So we know that some youth in their 20s and 30s are still living at home and remaining more dependent on parental support with things like finances, managing appointments, cooking. We know this is actually largely a societal change. It's shifted a lot with the cost of living in the Lower Mainland in BC, but also with just changes in how younger people are maybe taking a bit longer to get launched. Uncertainty about confidentiality and families with high expectations. So why is family inclusion important? So we know that if we involve family members as a key part of the care team, it can lead to improved patient and family outcomes, more culturally relevant and sustainable interventions, a reduced need for future utilization of acute health services, increased family awareness on how to support and reinforce their family members' recovery. This one is huge, right? Improved patient and family coping skills, reduced caregiver burden, increased social support for patients, and a very important one is increased likelihood of returning for necessary treatment due to a positive client and family experience. So if that patient and their family felt like they were treated with dignity and they really appreciated the care they got, they're much more likely to come back if they're needing more support in the future. And I'll toss things over to Steph to keep us going.
Awesome, thanks. So we're going to be moving into confidentiality and sharing of information. And so I really like visuals. And so one of the things that we found online was this idea of traffic lights of disclosure. So when you're looking at a traffic light, the red light would be something that you may not disclose. Yellow is something that you may or may not disclose, depending on the context or the nuances to that. And then the green light is something that you must disclose. So we're going to go through each of these, and we do have a number of scenarios to talk through. And so I'm looking forward to hearing everyone's thoughts on those. So starting with red light. So this one is when we cannot share information. So usually the process that we can look at is we can work backwards from an authorized disclosure to conclude that sharing of information is usually not authorized if the disclosure is not for the purpose of continuity of care. So it's not required to provide care to your client, patient, or family, and disclosure is not mandated by law. So in other words, the person requesting the information does not actually have the right or need to have it. We also do not want to be disclosing information if you are disclosing more information than the person you're disclosing to needs to know. So in a healthcare setting, we would be talking about things like treatment and historical psychiatric diagnoses, but we don't need to be sharing information that doesn't apply to their care. And the last reason you are not authorized to share information is a patient does not consent and the information is not required to provide care or access to services. So an example of a red light disclosure would be disclosing to a parent that their child, a 15-year-old female, is sexually active when the child presented to hospital for anxiety. So that doesn't necessarily apply to their anxiety or their mental health concerns, but it is important information to have as a healthcare provider, but that does not need to be shared with the parents. A note for this is that when we are considering the age of consent, so I do just have a little note here, if you're interested about age of consent in Canada and BC, there are certain situations where that might change. For example, if a child is interacting with an adult and we're talking about age of consent. So yellow light, I usually describe this as the gray area, which is usually where we work most of the time in psychiatry. Every single patient in every single situation is never going to be the same, even if it's the same patient you're dealing with two separate times. So when we are talking about yellow lights, these are things that you may or may not be sharing. So a quote from FIPA is, "One may disclose personal information for the purpose for which it was obtained or compiled or for use consistent with that purpose." So essentially, if you gathered the information from a healthcare setting and you are sharing it in a healthcare setting context, that is a reason to be sharing it. So this has been interpreted to mean that information for continuity of care, so providing care to patients or clients, is on a need to know basis. This does require some interpretation and healthcare provider judgment. Oh, I see a hand has been raised. I'm not sure. It has three
Yeah.
names.
Um, yeah, Natalie, hi.
Yeah.
I just have a question. So is the yellow light here mainly for like the clinical body more so than like if disclosing a family? Or like do you have an example where a yellow light situation could occur with like a family member or like disclosing to someone else in the care, like in the family?
Sorry, repeat that one more time.
Yeah, sorry, that was really confusing. I forgot what I said, but so for the yellow light, is it mainly for like the clinician for like the yellow light disclosure kind of thing, or like what's like a maybe, maybe not? Or would this also apply for like families and like disclosing to, let's say, a parent or a friend or something, or whoever's in their care team?
So for both. So yellow light can mean talking with, so clinician to clinician. So I'm sharing with a
Yeah,
healthcare provider, but it's also when you're working with parents or other patients or guardians, other members, like if they have MCFD involvement and things like that. So it is between clinician to clinician as well as parent, guardian, and
okay.
youth.
And then
Yeah,
do you
does
have an
that
example for if you're like what would be another example for like a yellow light situation with like between like a parent and like for the youth, like disclosing something about the youth to the parent that might be
so
like a
we
full person.
Yeah, so we actually do have four scenarios that we're going to talk through, and I do have four separate examples. So we can definitely, when we move through these ones, and we'll go into them. And I'm so looking forward to hearing from others because we do go through some of the yellow light of disclosure. And if
Sure,
there's still
thank you.
questions from you guys after that, I'm happy to answer as well.
Mhm.
And so PIPA uses something called a reasonable person test, which means disclosure of information is authorized only for the purpose that a reasonable person would consider are appropriate under the circumstances. So the reasonable person test essentially is if you line up 10 clinicians, 9 out of 10 of them are all going to say, yes, like you should disclose that information. That is information that should be shared. As healthcare providers, we provide care under FWIPA, so a lot of acronyms, but the reasonable person test is a helpful assist in gauging collection, use, and disclosure of information. So an example of a yellow light disclosure is that an 18-year-old patient is being transitioned from an adolescent to adult services. The clinicians provide handover to the newly receiving team on psychiatric history and treatment. And lastly, we have green light. So this is information that does need to be shared. So a quote from FIPA is that it mandates that information must be disclosed when there is a risk of significant harm to the environment or to the health or safety of a group of people or the public. So some really specific examples of that are when there is suspicion that a child is in need of protection. So in BC, a child is anybody considered 19 less a day. So anybody under the age of 19 requiring protection. When there is risk of serious harm. So just a note that anyone with reason to believe that a child is being abused or neglected or is at risk for this has a legal duty to report that concern to a child welfare worker within MCFD, so the Ministry of Child and Family Development, or to a delegated Aboriginal agency child welfare worker. So just a note here that if someone does disclose information to you that leads you to believe that a child is in need of protection, you do not need to require proof to MCFD. MCFD is obligated to investigate all of these allegations. There is also another note here that legal cases may involve medical record requests, but you should be connecting with your supervisor for instructions on how to proceed. An example that I gave at the last education session was I was working on an inpatient unit one evening, and police had showed up at our door and said, "We need this patient's toothbrush. We think they committed a crime." So in that situation, we would not be providing the toothbrush. So there are certain processes that are in place. So it is important if there is any concern about legalities that you're involving your supervisor or your leadership before following through with any sharing of information or toothbrushes. Note here, a child is considered anyone under the age of 19. For the purpose of this education, we are talking about 16 to 24-year-olds. So if someone is over the age of 19, the principle of duty to report under common or case law can apply. So that's applying to imminent risk, self-harm, or vulnerable people. And this should be also in consultation with risk management. And so a group discussion before we get into the clinical scenarios. Just a question for the group, and maybe we'll follow the same format as what Sarah just did. Take a couple moments to consider your answer, and then maybe we'll do a chat blast. So what are some reasons that a patient or client may not want to disclose information to their family, friends, or chosen family? So this is something that comes up a lot when we're working with children, youth, and young people. In your experiences, what are some reasons that you've heard that people may not want to disclose? Maybe I'll give another 10 seconds or so, and then we'll get everybody to share. All right, and feel free to share in the chat. Okay, just go to the top here. So fear of judgment or exclusion. Yeah, definitely. Self-harming behaviors. We hear that a lot with children and youth. We don't want our parents to find out that we're doing this. They might take our things away. Cultural barriers. Youth doesn't want to stress out family further. Yep. Self-doubt, fear, or shame. Yeah. Fear of repercussion. Yeah, definitely. Fear of getting in trouble, embarrassment. So a lot of common themes like shame, embarrassment, fear of being judged, fear of being a burden. Yeah, especially if other family dynamics are happening. They don't want to be the one that's causing more stress. Distrust. Yeah. Family may also have mental health issues and not wanting to be a burden or risking punishment. Fear of relationship change. That's a great response. Things are going to change if my parents find out that this is happening or that I'm not maybe as happy as I seem to be or something else is going on. Yeah, that's great. Thank you all for sharing. So just going through some of the ones, and I think honestly, I think everybody mentioned every single one of these, so that's great. So guilt or shame, stigma of mental health and addiction, as much as we'd like to believe that in 2025 that that's not the case. We know that there is a lot of stigma and a lot of shame around mental health and mental illness and addiction still. Reluctance to address their mental health or substance use concerns and seek help. So that can be for that stigma or fear of, or shame or embarrassment. And we know from our previous education sessions on demystifying working with young people that when people are afraid or have a previous negative experience, they're less likely to come back voluntarily to access services. And so that can create a lot of distrust if they have had a previously negative experience. Cultural or social stigma, which Sarah touched on in the last discussion. Denial of illness or severity of addiction. So that really speaks to insight. Differing beliefs or family conflict. So if family members maybe have a different idea of what the mental health journey should look like than the young person. Fear of getting in trouble. Desire for independence and privacy. So this is a huge one, right? Especially when we're working with teenagers and young people, they want to be in control of their healthcare, their mental health care, and what they do. But at certain points, they do still need the support of their parents. Maybe they're still living at home and their parents are their primary caregivers. So that becomes a bit more of a nuanced discussion. Anxiety and related avoidance about the uncertainty of illness and care. So not knowing what's going to happen. What is the system? What does it look like? What is going to happen to me? Am I going to have to stay here? And then lastly, feeling like a burden. So pretty much everything that everyone mentioned in the chat. So that's great. And so moving on to our discussion scenarios. So we're going to try, we haven't done this yet, so I'm hoping it'll work. We are going to do a poll for these. So we have 4 different discussion scenarios. We're going to go through them one by one. And so you're going to read the scenario, and I can read it out as well. And you're going to select red, green, or yellow, whether you will disclose, not maybe disclose, or not disclose. And if you do say yellow, maybe disclose. If you want to share in the chat, what questions or what more information would you want to know if you were going to disclose or prior to disclosing? So if there's anything that you're like, I might need to know more about this, feel free to throw it in the chat. So the first one here is a patient is a 24-year-old female. She's being admitted to an inpatient psychiatry unit for an intentional overdose on Tylenol. She doesn't want her parents who live in Mexico to know any information about her admission. Do you need to contact her parents or disclose any information to them? So I see a couple people are responding. I'll just give people about another 10, 15 seconds. And for those of you who have said yellow, is there anything that you would ask? More information. Yeah. Some more info. Who would she consider a near relative for Mental Health Act forms? Great. So if we're not going to be contacting the parents because she's 24, parents are living in Mexico, she doesn't want them to be aware, who can we contact, right? So it's not, okay, we're not going to share any information, discharge on your way, here's some resources. Who is this person connected to? Do they have a roommate? Do they have a partner? Do they have family here? Who can we ensure is included in their care and can support when they're leaving the hospital? So if there is no one, that's a very different story. But if there is someone, then we do want to ensure that that is an option for them. So I see, oh, perfect. So Sarah, are you able to share the results? You have them there?
Yeah, I think I'm sharing them right now. Are people able to see
Okay,
them?
perfect. Yeah. So I would say, oh, half and half. So half red. Yeah. So do not disclose. And then yellow, half of you. Yeah, great. So there's more information needed, but as far as the question, would you need to share information with parents? The correct answer is red, but yellow, of course, knowing that we do want to ask further information. So that's a bit of a trick question. And I will give you a tip. Most of these are a trick. So, okay, we can go into the next one here. So a patient, 14-year-old male, discloses he blacked out drinking alcohol last weekend and crashed his bike. He is here in the hospital for a sprained wrist. Do his parents need to know about his drinking? So red, no, they don't. Green, you have to disclose or you should disclose. And yellow, it's a bit of a gray area. There's more questions I would want to know. And so if you do say yellow, please feel free to share in the chat what maybe questions or what more information would you want to know? I'll give everybody about another 10 seconds or so to answer. Great. And so some comments in the chat here for those who have selected yellow. So would require more context about the drinking and the risk of harm. Is this the 13th time he's come in this year for drinking and there's some physical accidents? Or is this the first time he's ever even interacted with healthcare in the first place, right? So those are two very different situations. A question, is he in the custody of his parents? Another comment here, I'd want to know more about the context of the drinking. Did he have any intention to harm himself or drive his bike recklessly, indicating plan intent regarding self-harm? Yep. Is this the first time they've done something risky while drinking? So that's a great question as well. And then if disclosing to parents, would it cause him more harm with them knowing? Great. And so I'll get Sarah to share the results here. And so a bit of a mixture, actually, I would say majority of people said yellow, but we do see some green and we do see some red. So I think this is definitely a situation where with the age, it's very different. So when we're talking about a 14-year-old versus a 24-year-old, I think responses would change. But this conversation is around a 14-year-old. And so I think the questions to ask and the answer would be yellow in this situation. We would want to know more information. Was there any intent behind the crashing of his bike? Is this the first time that this has happened? Is this also an opportunity to do some brief intervention? So when we think about, yeah, and is this an ongoing concern? Exactly. So is this an opportunity to provide some brief intervention or even do a brief assessment of the substance use? Maybe there is something more going on and an opportunity for some early intervention or resources if the young person is interested in that. And when we're talking about drinking and we're talking about early intervention, also understanding maybe how his mood is doing. So there's a number of questions that we would ask, but for the purpose of sharing the information with his parents about his drinking, we would need to know the answer to those questions in order to determine whether or not we would share. At face value, if this is the first presentation, I would say it's unlikely needed to share with the parents. But if there is more nuances to that, like this isn't the first time, there is some intent of self-harm or risky behavior, or some concerning substance use, then we would want to have that conversation with the youth first and go from there. Okay, third. So a patient, a 23-year-old male, is being discharged from the inpatient psychiatry unit to his parents' home where he lives. He was admitted for psychosis and paranoia related to his parents poisoning his food. Do parents need to know any information about his treatment? So red, you would not disclose. Green, you would disclose and you must disclose. And yellow, more information is needed. And if you do select yellow, what more or what information do you think parents would know, or what questions do you anticipate parents might ask that they might need the answers to? So I'll give everybody a couple seconds to finish the poll. And then if you feel like you have a question that you would want to know or that the parents might ask, and you responded with yellow, feel free to drop it in the chat. Great, lots of responses coming in.
And if anyone feels like it's easier to participate by unmuting and kind of talking out what you're thinking too, that's also totally fine. So we want to make space for whatever kind of way you want to participate.
Great. Yeah, so somebody in the chat commented that he might not be able to make sound decisions at this time. Yeah, or there might be some level of impairment still. Yeah. And then more information needed. So is there going to be a care meeting? Is there personal safety concerns? I would say personal safety for the youth or young person as well as the parents. Does he want the parents to know? Is he totally okay with parents knowing all that information? Or has he said, I don't want my parents involved in anything? Another question as well as medication compliance. Yeah, that's a great thing to consider. And then is the youth disclosing any paranoia or intent to, quote, protect himself, retaliate, or harm his parents? Concerns about duty to report on risk to parents. Definitely, these are all great answers. From an epi standpoint, families are usually involved in the treatment process. That's a great thing to know, is that families are usually quite involved. And that is kind of the epi model, is that wraparound support. Okay. So for this one, everybody that put comments in the chat, these are some great questions to consider. So this one would be yellow, depending on what the information is we need to share. So although he is an adult, he is living with his parents. There is a history of some psychotic symptoms that involved paranoia and possible risk to his parents. And so it would be helpful and important for the parents to know that. So what were the previous concerns? Worries that his parents were poisoning his food. What does relapse look like? So if he becomes psychotic again, what are those symptoms that we want to look out for? Because he might not be able to recognize them right away. But if he's living with his parents, they're providing care, they're checking in on him regularly, they would be the people to really notice those symptoms. Is he not sleeping? Has he started using substances again? Is he talking to himself? Is he seeming guarded? So these are the things that they would want to know. Second to that, is he on any medications? What is the medication? How often does he need to be taking it? If it's an injection, does he have a follow-up appointment? When is that? Does he need support getting to that appointment? So you can see how when we're talking about yellow, it's not no information is shared. It's more of a conversation. What information does need to be shared in order to support this person going back into the community? So everyone's responses were great, and I'm glad that everyone's kind of thinking about that. And it's, I think that lens of the parent as well is that they want to help support, and how do we do that? All right, and then Sarah, are you able to share the results of that one? Great. And so we have one more discussion here. So a patient, an 18-year-old non-binary person, is admitted for an accidental drug overdose, and their parents are out in the waiting room worried about them. They say that they do not want you to speak with their parents and are worried they will find out about their substance use. Do you need to tell the parents about the overdose? So no, red, you do not need to disclose. Green, you must disclose. And yellow, there are more things that we might need to know. And then if you do say yellow, feel free to put some questions you might have or some concerns or things that might change your perspective in the chat about the disclosure. I do want to note that this is probably the trickiest one and the one that we usually get a lot of discussion out of. So feel free to put up your hand or comment in the chat. And I'll give everybody another couple seconds. And if anybody is wondering about the accidental drug overdose, this would be something like an illicit substance, not something like Tylenol, if that helps for that lens as well too. I see a lot of majority of people have put down either red or yellow. So anybody who's put down yellow, is there any information you might want to know or any questions that you have? Okay. I'll give everyone another second or so here. So this one is quite a tricky one. I will, oh, I do see a comment here. Okay. Talking with the youth regarding what their concerns are with sharing the information. So what are they worried about? What their existing support network looks like. If there are aspects of the situation they would be comfortable sharing, but not others, i.e. maybe not the ongoing substance use, but maybe that they did have an overdose. Also knowing past conversations the family has had regarding substance use, essentially just more to understand the context. Exactly. Yeah. So there's a lot more questions that we can ask, right? And this would be helpful information to know before even going and talking with a parent. Another one here says, explore why they don't want the parents to know. Is someone talking to the parents, asking them for info? Families could be trained in take-home naloxone administration, which would be ideal. Definitely. So these are all really great responses. So out of the 4 scenarios, like I said, this is one of the more nuanced conversations. This is actually a scenario that has come up in my own practice. The age was slightly younger, but the concept was still the same. So this was a situation where the parents were just notified of their child being taken from school in an ambulance. They weren't notified of the overdose. And as you can imagine, as a parent rushing into the triage of the emergency department, terrified that something has happened, there's a lot of emotions going on. And so from the perspective of the young person not wanting to share information, it is important to understand, are there risks associated with disclosing the information? Are there risks of harm? of the family being told this information? Are there risks towards your rapport and your engagement, as well as like legalities of sharing the information? And what is kind of like the ongoing plan? So are they all like the overdose has been reversed, they're medically stable, they're okay to go home, or is there needing more ongoing treatment? Maybe there's some concerns there with physical health. Is this something that has happened multiple times before? So these are all questions that you would want to ask. And then understanding and speaking with the parents. So I'm gonna, after this one, we will go into a bit of a slide about sharing of information and collecting information. I will go kind of into that, but in the context of working with the family, and my experience working with this patient was that I did briefly go and speak with the parents after speaking with the young person. The concern was that they didn't want their parents to know because grad was coming up in 3 weeks, and they were really worried that they wouldn't be able to go to their grad ceremony. And so this was quite a serious concern for them. And it may be, maybe we wouldn't consider that as a serious concern, but that for that young person, that was one of the most important days probably of their high school life. And so having that taken away is like a very big fear. And so I went to go meet with the parents, and I inquired about what their understanding of the situation was. They didn't have any information. Is my child okay? Your child is safe. They're here. We're just trying to find out more information. So when I went back to speak with the young person, I let them know that their parents were in the triage waiting area. And I did share with them that their parents were really upset. They were really worried. They were really scared. And so what ended up happening was is that the young person actually became quite tearful and asked for their family to be brought in. And so it is important to acknowledge that confidentiality is an ongoing conversation. And so if there's one thing that you take away from this, I think for me, it would be ensuring that it's not just at the beginning of every assessment or conversation you have, it's a yes or a no, it's an ongoing conversation. And so in this situation, it was just that fear of graduation, but I think we can acknowledge from the parents' perspective, they're probably just more so happy that their child's okay and that they're safe. And so it is just an ongoing conversation with the youth, with the family, with the caregivers, and understanding what is going to result in the best care for everyone involved. And we do have just one more comment that came up here. I think families should be involved so they can reach out for more supports. Exactly. And the
And
comment above.
if I can
Oh,
jump in really quickly, one thing I've learned from Steph that's really helped me in my practice is, say you do have a case where there's a youth and you determine that you won't be disclosing the substance use to the family, but there are some ongoing risks of that youth engaging in substances. Steph has in the past, like with Narcan teaching or teaching them how to use a kit, she has just kind of gone to families and said, hey, I do this teaching with every family of a young person, or I offer this teaching to every family. Are you interested in learning about how to use this in case it ever comes up? And that's not disclosing substance use. That's just saying, hey, with the safety in BC right now with what's going on, we know some young people sometimes try stuff. So if this is something you're interested in getting teaching, and I can do that with you. So I thought that was a really, really nice approach, and a way to kind of do a bit of that harm reduction without a disclosure going on around substances.
mhm. And also just a note, for, I work at BC Children's Hospital and previously at Surrey Memorial Hospital, so I can't necessarily speak for areas outside of that. But I would say that majority of substance use programs that I've interacted with are actually willing to accept referrals, even if the young person is not willing to engage, they can provide that support for parents. So as long as the parents' contact information is there, that is also a resource that's available as well. I see, Sherry, you have your hand raised. Go ahead.
Oh, hi. I just have a question for you. Like, I'm with Coast Mental Health, and I actually experienced my daughter. She had an overdose 2 years ago at Children's, and thankfully she's doing well now. And but what I wanted to point out is one thing in my experience is as a parent, right? Um, the parents, it's overlooked. A lot of support is there for the child when we're talking about this, but say I was handed a piece of paper with Holding Hope and a few other people, but I feel, and maybe just in my case at the time, not enough focus versus a 1 minute conversation with me and a piece of paper for support for the parents. Like, it should be, I believe, here's a list, would you like somebody to call you, like, who has been there, because as a
Mhm.
parent, you're so overwhelmed. And I believe, having the support of other parents and a whole scope of other things and my own lived experience has helped me get her to this point, but it would have been very helpful. The other thing is, I'm confused on the age of consent. She was 14 at the time. And again, at the time, as a parent, you're so overwhelmed. I must have asked 10 times what was the drug and, what was her blood work. And and when I look back now, it was avoided. I still never found out. So, and I'm still confused. Like, what is the age of consent? And I believe that the notion of the view of parents many times, and I know not everybody's family life is perfect or great parents, but I think it's too lopsided on the view as doctors and the staff of I know there has to be safety and concern and all of that, but also, and I've met many parents who have experienced this with their children in groups and other settings, that not enough weight is put on to good parents, loving parents,
Mhm.
the
Mhm.
prejudgment and the view of someone in active addiction, wanting to acknowledge that, my parents are bad, and as a person with previous addiction and 6 years sober, a reason to use. So I don't know. I don't think the whole scope was completely covered. Also, if a youth agrees to share information, at the same point, acknowledging that, if you change your mind, this can be changed. That all or nothing is very scary, not only to youth, but really to everybody. And definitely, someone to be, here's the piece of paper, you can review it as a parent, or would you like someone from the Hope group to call you?
Mhm. Yeah, thank you so much for sharing. And I think it does speak to a number of challenges, especially with the drug overdose crisis happening right now. I know I see a lot of parents in the news coming forward and saying, we weren't told anything. How am I supposed to help if we're not being given any information? And so I want to just acknowledge that it is a very difficult situation. I think on the lens of the parents providing care, you take the child home where the providers for the short period of time that they're in the hospital or in the clinic. I would say with regards to the age of consent, so the results of lab work as well as urine drug screens, including pregnancy tests, are not under that for age of consent. So that is information that is never shared, only with the client themselves. The records can be requested, and that goes through health records. But as far as providing the support for parents, I definitely agree, talking with the family. And that's what this following slide here is to say. Even if you have a young person that says, I don't want any information shared with parents, if it is a situation where they are living with family and there is relevant information that parents want to share, under the Vancouver Coastal Health Policy, and other health authorities will also have policies around this. This is just Vancouver Coastal Health. Is that you do have the ability to gather information from parents or guardians or partners, whoever is relevant to the care. And so this is information that you can collect for that. And as well as the point that you spoke on about resources for parents, there are a number of parent resources that we do have that we want to share at the end as well. But I do agree, having those support for the parents. So do they have an understanding of an overdose and the take home naloxone kit? Can we do that here today? Are there parent resources that we can connect them with that's more than just a piece of paper or a website? Is there someone that can follow up? And these are all really relevant questions to ask, especially coming from the lens of a parent.
And
And
I
that,
just wanted to jump into just to thank you for sharing that lived experience. And this is part 2 of our family-centered care education this month. And our other part talks a lot more about the importance of supporting families and bringing caregivers in and all of the resources there. And so our hope with this education is that families are brought into care more rather than less. And so I think having these conversations about the gray areas is so important, because the ultimate goal is we want families to be involved more, because we hear stories like yours and from we've had a lot of family focus groups and caregiver focus groups, and we hear that a lot. And so that's a big focus and goal of our education, is that we can support that conversation and help teams realize that they can involve families more than they realize. I think I saw another hand up
Yeah,
as well,
that's
but then
great.
it went away.
Thanks.
Thanks, Sherry. Did someone
Thank
else
you.
still have their hand up? I think it was Leah.
Hi, yes. Thank you. I just wasn't sure about time, so I'll just keep my comment brief. I just for a parallel observation, I think if a child practice, like, I work with a lot of children who self-harm, and I think if a child practiced self-strangulation or cutting, and it got extreme to the point they passed out or they bled out and needed medical intervention, I think we approach involving family much quicker and from a different lens of definitely, or I think there's a lower bar that we would involve families, so I just think it's an interesting parallel to think about. That's all. Thank you.
Thanks for sharing. And I think one of the two takeaways now is one is that confidentiality is not a one-time statement, but two, the importance of working together with your team, working with the family, working with the patient or client, to really understand kind of what needs to be shared, what are the risks, and having that conversation. I think the worst thing as a clinician is feeling like you're alone in any of this, in any aspect of your job, let alone feeling alone to hold all of this. And so I think it is important, and it really speaks for the importance of teams, and having someone to share kind of that information with, and to go through that process. And what are the risks? What are the risks to sharing the information? What are the risks to not sharing information? And so your comment on some severe types of self-harm, we would need to have the family involved in that. So what does that look like? Sarah mentioned that we've been hosting a number of focus groups. We recently held groups with healthcare providers, family, a separate one with family, and a third one with young people who have either been in the system or currently in the system. And I think one of the biggest things that we heard from young people is that it's not that they even mind that the family is involved. They usually want their family involved. They want their family to know certain information so that they can help them. It's that they didn't know what was being shared. They didn't know what was being done with the information, and that they felt like they weren't consulted. So it's not that they would have said no if they were consulted. They just want to understand what is being shared. So I think having that takeaway and knowing that young people do have an understanding of why their family needs to be shared, with information needs to be shared, but just feeling like they're brought into the loop on that as well too.
And I think what was so striking for me was that a lot of them as a teenager had a lot of difficulty with how information was being shared. And then when they turned 19 and they were in the adult system, they actually voiced being disappointed that family wasn't involved more. So I think just a big takeaway is that teens and young people do really, really want their families involved, but just a very youth-focused approach at helping them be informed and help to dictate how much information is shared, or making sure that you can validate their concerns and work with them. Just while we're finishing, we do have the QR code up on the screen, and we've also popped it in the chat. And then to very quickly go over the family resources.
Oh, yeah.
I'll just
Sorry.
get Steph to move the slide. So this slide has some clinical resources for healthcare providers, and there's a slide for families as well. So we'll send out all of these slides, but Compass, again, all across BC, healthcare providers can call and get support for 25 and under for mental health substance use, with a really great interdisciplinary team. We have some work here from Family Smart, again, talking about supporting families and helping a family member maybe connect to other parents or parent peer support workers who have also supported a loved one with mental health. We have many other things in here related to Kelty, so any sort of education or helping families feel more informed and empowered over their medications. We briefly mentioned the VCH family involvement policy for all of those of you coming from VCH. And then some other quick resources to pull out here. So the Sash Bear Foundation offers free virtual groups for caregivers that is DBT based, for supporting DBT skills for families and caregivers at supporting their loved ones. We have Foundry. We have some of the fantastic peer support workers from Foundry on the call today. So shout out to Foundry. But there is parent and caregiver counseling. And so even if a young person isn't connected to Foundry, their caregivers or family can come in and access that caregiver counseling, which is excellent free drop-in resource. The last one I'll highlight with our time is just the BC Schizophrenia Society. It's not only a support society for schizophrenia, it actually supports families supporting a loved one with any severe persistent mental illness, and they support with free service navigation. There's different service navigators for different regions of BC as well. So another really, really great resource to consider, and we will send all of this out with the toolkits and everything as well. So we'll stick around another minute or two just in case there are questions. But we really appreciate all the participation today. And our next, in April, our theme will be transition and discharge planning. So we'll have another group of education sessions next month, and we'll send out info about that as well. Thanks, everyone.